As you know, the first talk will be the abstract or the poster winner from yesterday's poster session, and this will come from Vanderbilt University, clinical fellow, and this will be Justin Hewlett, clinical features, outcomes associated with telomere pathway mutations in familial interstitial pneumonia, and that will actually lead perfectly into our first presentation afterwards. So, Justin, stage is yours.
All right, well, thank you very much, and I can't thank you guys enough for giving me the opportunity to talk about some of our research that we're doing at Vanderbilt. So just to get started, clinical features, outcomes, and familial interstitial pneumonia. Let me see if I can get this. There we go. I wish I had disclosures, and fortunately I don't have any at this time. So the first thing that I want to talk about is a little bit of the background. You've heard a lot about the genetics of pulmonary fibrosis, and we know that 1 in 5 patients that comes into our clinic has a family history, has something that we think is running in their family that's causing them to have this fibrotic disease. A large portion of that is associated to some of these more common variants, MUC5B, TOLUP, and then there's a rare group of genes that are mutated that have a much higher association with disease. Those can be broken down into 2 separate categories, or the surfactant proteins, as well as the telomere pathway proteins, which is what we wanted to look at here today. If you look at those telomere pathway mutations, not everybody has a UIP pattern on their CT scan, and not everybody ultimately gets diagnosed with a pulmonary fibrosis as their diagnosis, but the histopathology doesn't necessarily correlate with their clinical outcomes either. So what we wanted to look at is, can we compare some of these patients who have familial interstitial pneumonia with a telomere pathway mutation to those patients who had familial interstitial pneumonia who did not have an identified telomere pathway mutation, and again also look at those compared to sporadic IIP patients. What we do at Vanderbilt is we look at these families and we say, okay, we know you have multiple subjects here who have interstitial lung disease, and we're going to take one of those and say, okay, let's look at your exome, do whole exome sequencing, see if we can identify one of these rare variants, less than 1 in 1,000 variants, that might be the cause of the disease. Now, you might think, well, you just find one and you're ready to go, but what ends up happening is we find several, and what we need to do is do targeted sequencing to several other patients within the family, and eventually we can narrow this down to one gene that seems to be driving this. Once we've done that, we can take all of those patients and look at the ATS-ERS criteria and separate them into disease categories, and then we can look at those patients who did not have any mutations. We chose to use RTEL, TERT, and TERK as our most common mutations identified in the telomere pathway, and then looked at those patients who had no identified mutation. So if you look at our data, if you look at RTEL, TERT, and TERK, those are comprised about 17% of our familial interstitial pneumonia patients. And you can see we had pretty good numbers. There's about 300 or 250 patients who are within that, and then there's another 270 within the familial, and then we had another 100 almost that were with the idiopathic interstitial pneumonia. So trying to compare these groups, what you start to see stand out is that the male predominance of idiopathic interstitial pneumonia goes away when you look at familial cases, and especially familial cases that are associated with telomere mutations. And separately, if you look at their age at diagnosis, these patients seem to come in about 5 years earlier on average, and looking at that along with their forced vital capacity and their DLCO, those seem to actually be relatively even, suggesting that maybe these patients just show up when they get to a certain disease level, but may be happening earlier in these patients who have telomere mutations, and that's true even if you compare it to these other familial patients. Just to confirm, we got the group that we were looking at, the telomere lengths. Don't know what is happening here. I don't know. Yeah, no, it just decided to go racing forward. No longer working. Not working. There we go. Got it. So our telomere lengths, and this is corrected for age, are far shorter in our telomere pathway mutations. There are some folks within the other familial interstitial pneumonia and the sporadic idiopathic interstitial pneumonia groups who had short telomeres, but on average, they were much longer than the patients with the telomere pathway mutations. We still had variability of disease. There is still a majority UIP, IPF, but what we started to see was there was a lot more patients with unclassifiable ILD, and there was also a group of patients who had PPFE, which you really didn't see in either of the other groups. Importantly, when we looked at their progression in FVC over the course of a year, the FVC declined at almost twice the rate of those that did not have a telomere pathway mutation. And then we looked at alternative non-pulmonary disease manifestations, knowing that these were shown in prior studies. And it's true that these FIP patients that have telomere pathway mutations are far more likely to have liver disease, bone marrow disease, and especially solid malignancies. And if you think about solid malignancies, you'd think, well, these patients have lung fibrosis. They're already at increased risk of lung cancer, but only about half of them had lung cancer. There was a group that had astrocytomas, sarcomas, ovarian cancer, bladder cancer. So it was actually relatively mixed. And then lastly, if we look at association with the MUC5B promoter polymorphism, you were less likely to have that if you had a telomere pathway mutation. And I think this makes sense because you already have a driver for your pulmonary fibrosis. You don't need another risk factor here. So in summary, what we were able to show is patients with telomere pathway mutations compared to those who had non-telomere pathway mutations or no identified telomere pathway mutation were more likely to have earlier onset disease. They were a little bit more difficult to classify. They had more rapid progression in their FVC, and they definitely had an increased association with non-pulmonary diseases, specifically liver disease, bone marrow disease, and other solid malignancies. And thinking about this and how to put it into clinical context, it may be that we can use this information to say, you know, this patient has a family history. We might want to send off a telomere length if their telomeres are short. Maybe this is the right thing. We can test for them, and that way we can give them a better prognosis of what to expect going forward in their lung disease. And with that, I'd like to really thank John Kropsky and Tim Blackwell for supporting me through my research and helping me out with this project as well. And any registry project with a number of families this large requires a large group of people, not only to recruit, but to sustain activity within the cohort. And I can't thank everybody up here enough. And again, thank you to the PFF for allowing me to present my research.